Hi guys, welcome to another edition of Ask the Doctor Lecture Series. With the Health Insurance Exchange coming up, I thought I'd do a three-part series concerning health insurance and to really educate our members and really the public as far as what you're paying for. So I thought we would break this out into three distinct parts to kind of understand why things cost the way they do, why things are kind of overinflated, and how to best utilize your healthcare dollar. So today's segment will be specifically looking at how docs get paid in the real world to give a little bit of insight into why the cost of medicine is so high, why physicians see so many patients per day, and it really comes down to having a little bit of understanding about how the business world works. So before we get too far as where we are, let's get an idea of where we have come from to see what the current scenario is. So back in the early 20s and 30s, there was a movement through Blue Cross Blue Shield in Texas to actually do the right thing, where they said, you know, we're going to go ahead and contract with a bunch of physicians. We're going to charge patients an equal amount, no matter what their background is, no matter what their health situation is, and we're going to have them pay into a fund. And that fund will be used to kind of help offset some medical expenses, especially in the hospital. Those premiums, I think, were anywhere from $6 to $7 per month, and it gave you up to 21 days of hospital coverage. So that was back in the 20s and 30s, and then as World War II happened, then we began to have private investors looking at the insurance world saying, hey, this is a pretty good marketplace to make some money, and then employers were also looking at other ways to not pay top dollar for essential workers, and they were using health insurance as a leverage tool to allow them to kind of reduce wages or keep wages flat by incorporating health insurance into their package, and this kind of started the boom of the employer-based health insurance world. So we can go ahead and fast forward 60, 70 years now. I think we're all pretty familiar with the challenges that we all are facing. Health insurance premiums, meaning the money that you pay every month, either as an employer or as an individual, keeps on going up between 5 and 25% annually, and the amount of coverage that you're getting, meaning that the amount of dollars that the insurance company will pay for your health benefits is reducing, if not getting more scrutinized. The deductible, which means the amount of dollars that you'll pay out of pocket first before your insurance coverage will actually kick in, has been increasing steadily. The latest report I read says that the average deductible is around $2,000. So the first $2,000 comes out of your pocket plus whatever you're paying from a premium. So why is the situation this way? So every year there is a group of physicians that meet in Congress. It's called the RAC Committee, and there's 26 docs that kind of sit in a room, and what they do is they assign a numerical value to every type of procedure that's done, every type of test that's ordered, every type of medical device that's out there, and they assign it a monetary value. And that value then is evaluated through CMS, and it's kind of implemented as far as a standard. So what this means is that a sore throat, for example, has a specific code that's associated with that, and that code is then multiplied by a factor depending on your specialty, and then that equates into the amount of dollars that are given to you, and that's illustrated in the graph that you're taking a look at. So essentially it's a CPT code, which is the fancy term for what happened in the office times a conversion factor, and that conversion factor is what the RAC committee will decide which specialty is worth more money. So typically the specialists, meaning cardiologists, gastroenterology, etc., surgeons, they have had a higher conversion factor, and primary care, such as internal medicine, pediatrics, family medicine, have had a lower conversion factor, and that gives you your total dollars. If the same procedure is done, so meaning that if a ear lavage, meaning I'm washing an ear out, is done by an ear, nose, and throat doctor versus me for the exact same procedure, the ear, nose, and throat doctor will get paid more because they have a higher conversion factor than, for example, like myself as a family medicine doc. So that gives you an idea of the gross dollars that are coming into a physician's office. So that sounds pretty honky-dory, pretty straightforward. But here's really where the problems really begin. So first and foremost, to get paid, it's called reimbursement. So it means pay you back. So that reimbursement, to even get the money back, a physician has to spend about anywhere from between $80,000 and $90,000 per year to be able to interface with the insurance company. So each company has its own form, each company has its own process, and typically it takes a whole financial team to get that money that you've already, for the services already rendered. So it's like if you went to go get your oil changed, the oil change was done, and then all of a sudden you have to negotiate to get that money for the oil change with a third-party payer to get money for a service that was already done. So it gets a little bit convoluted there. The second issue is that besides having a financial team that costs anywhere from $80,000-$90,000 a year, is that insurance companies can simply withhold charges. So it's called a rejection rate, and a rejection rate typically runs anywhere from 25 to 30% on average. So meaning that the first time that a doctor submits a claim to get paid, insurance companies will go ahead and just automatically reject it. And this practice is pretty widespread, and insurance companies are pretty savvy, so they know behaviors from physicians and physicians' offices, and a lot of docs, what they say is, it actually costs me more money sometimes to try to get money, so we'll just go ahead and write that 30% off. So some practices work on that aspect. Other practices have a larger employment staff for billing purposes and getting money back, and so they'll try to resubmit to get those claims. The other kind of factor with that is that insurance companies can simply stop paying based on a particular code that you used. So an example of this is you come to see the doc for bronchitis, for example. Recently, Regent said, hey, we don't want to pay for bronchitis anymore, so they just stopped paying. There's no notice that was given. There was no kind of formal letter that was given to physicians' offices. They just stopped paying. And physicians' offices, it typically takes anywhere from 30 to 60 days to get paid. So it takes about anywhere from 2 to 3 months to figure out if you're getting paid for a particular diagnosis, because you have to go back through all your records to figure out, hey, why is my check from this insurance company lower this month than it typically is? So you kind of have to hunt and deduce what the insurance company deems as an appropriate diagnosis versus not. Thirdly, when it comes to smaller private practices, there's very little, if no, negotiation power. So meaning that as a solo doc, if you're taking insurance, the insurance company will basically tell you what they're going to pay you, and there's no ability to negotiate based on how good you are. You could give them the data that's saying, hey, look at all my patients, I'm keeping them healthy, I'm keeping them out of the hospital, I'm decreasing their utilization of resources. You can give all this data, but at the end of the day, because you're a solo provider, you have very little negotiation. Versus a larger group like Polyclinic, UW, those kinds of entities, they have lots of physicians, and so really they can use the same data and say, hey, our docs do X amount of good work, but really it's their fact they have so many docs under their umbrella that they can go kind of toe-to-toe with insurance carriers to negotiate a better rate. So this kind of plays in the favor of the larger organizations, which has, I think, issues in itself. So listed below is another example that we'll kind of go through as far as how docs get paid. And we'll use Medicare. Medicare pretty much sets the standard across the board as far as the bar for what physicians are going to get paid for a certain procedure or for a certain office visit. So we use a simple sore throat office visit. Medicare will typically reimburse a primary care doc around $40 for that office visit. So again, it takes about 35 to 45 days to get paid. You have a medical staff and a financial staff that you have to use to kind of help see that patient and bill for the patient and get the money back. and that costs the practice about $55 for that patient. So here we are, we have amount of money of $40 coming in with $55 going out, so it's a minus $15 net revenue. So we've lost money on that patient. So what practices will do, they'll limit the amount of Medicare patients they see. Just financially, for any business folks, if you're not getting enough dollars in versus going out, that's usually not a very sustainable model. If we kind of go a little bit further with this example, Medicaid, which is the state-funded insurance, meaning the taxpayer dollars that are being used at an individual state basis to help low-income families, they pay even less. So that same sore throat that Medicare gave us $40 for, Medicaid will give us about $30. So we go from a net loss of minus 15 to a net loss of minus 25. So again, the practice is now out more money, and the kind of solution for some practices is to limit the Medicaid. And what they try to do is limit the Medicare amounts, limit the Medicaid amounts. Each practice will state, hey, we're trying to do the right thing, which I fully agree with, and then have more of an insurance base to help offset some of that cost. So what this results really is, when you just look at the financial demographics, is that you really have to kind of churn and burn, meaning that you have to see a lot of patients just to kind of make sure that your overhead is getting met. So overhead means that you got to pay for the financial staff, you got to pay for your receptionist, you got to pay for your medical assistant, you got to pay for the telephone, you got to pay for all these bills, and that lump sum of money needs to get accounted for. And the only way that you're going to be able to pay the bills and eventually hopefully make some money yourself is that you have to see quite a bit of volume. In a typical primary care office, the first 16 patients seen per day goes to overhead cost. So that's 16 patients. After the 16th patient is typically when the physician will actually begin to make some money themselves. This results into the current situation. When you have to see a patient every 15 minutes to 20 minutes to make ends meet, you're seeing about 24 to 30 a day. I used to see about 28 on average a day in the traditional insurance world. And what that creates is yet another scenario where you're seeing a ton of volume. Patients are coming in expecting to have time with their primary care physician, but you're not allowed to do that simply because of the low reimbursement and the huge overhead that you have. So really, the question I'm hoping that some of you are asking is, how does that pertain to me? I don't have Medicare and Medicaid, but this does play into the role of the new Affordable Care Act and its small kind of fine writing details that was put into the bill. So if you have a brand new Obamacare card like I do, the rates that were negotiated prior to implementation had a small little subset where any insurance carrier that was going to offer the Obamacare exchange plans had to match the rates of paying doctors at the Medicare level for the year of 2014. But in 2015, that portion of the bill essentially expires, and the rates for reimbursement are going to be going down to Medicaid levels. So if we go back to that kind of sore throat example, if you had the Obamacare Affordable Care Act card, that sore throat, the doc would normally get $40, will now drop to $30, which essentially means that more physicians will begin to not accept the Affordable Care Act cards simply because financially it would drive them out of business. And the larger institutions who can carry a little bit more weight of that financial burden are going to become the centers for the Affordable Care Act. So hopefully this gives a little bit of a insight into the financial aspects behind a physician's office and how physicians get paid. Because ultimately, whether you like it or not, healthcare is a business, and there is cost associated with being a physician, and those costs need to get paid back somehow. So our next series will talk more about alternatives to the Affordable Care Act and how actually it can be more financially suitable for individuals. Thanks, and have a great day.